Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association EHA. My name is Isabel Olivera and I'm a medical writer for the EHA. I have the pleasure to have here with me today Professor Pieter Sonneveld. Welcome, Professor Sonneveld. Can you please introduce yourself?
So I'm Pieter Sonneveld. I'm a professor of hematology at the Erasmus Medical Center and University in Rotterdam, the Netherlands. And my special interest is in multiple myeloma, in particular the organization of clinical trials with novel agents for multiple myeloma and translational studies focusing on risk factors for patients treated within those protocols.
So we're going to discuss today the current precision medicine approaches to the treatment of multiple myeloma. To start with, can you please explain very briefly what is multiple myeloma?
Multiple myeloma is a bone marrow cancer. It's originating from the plasma cells, which are cells in the bone marrow that produce antibodies against infections like bacteria and viruses, and are present throughout life in the bone marrow. Every time we hit some bug, virus or bacteria or whatever, the plasma cells start to produce antibodies to fight the infection. In multiple myeloma, one or more of these plasma cells have become malignant, meaning that there is many more of those plasma cells of that single type in the bone marrow than is required for normal function. And these cells grow autonomously and produce large quantities of the antibodies, but they are not functional. So patients with multiple myeloma, they suffer from several complaints. First of all, because the plasma cells grow in the bone marrow, the normal blood cells are going down, and so patients have anemia and thrombocytopenia. Second, the proteins that these abnormal plasma cells produce, they can clog the blood, they can clog the kidneys, leading to renal insufficiency. And finally, these plasma cells, they attach to the bone and they may result in bone lesions or ultimately also fractures. So it's a disease with many aspects, and the incidence in Europe is about 6 to 7 per 100,000. So in the world there's around 175,000 patients each year. So it's the number 2 blood disease, and treatment is important because otherwise if patients are not treated, they will die within a year. But we are very happy to live in a time where there are effective treatments.
Yes, over the last years, there have been many novel targeted therapies for multiple myeloma. They have been introduced into clinical practice and have dramatically changed the treatment landscape for multiple myeloma. Can you give us a brief overview of the most important types of targeted treatments currently available?
Yeah, so let's start with discussing very briefly what the standard treatment was until, let's say, 5 years ago. Bortezomib, which is a proteasome inhibitor, is a very effective drug in multiple myeloma. And also the IMiDs, the immunomodulatory agents like thalidomide and lenalidomide, those two have been the part of the backbone of myeloma treatment. And in younger patients, let's say until 65 or 70, that are eligible, autologous transplant that's following high-dose melphalan as a bone marrow ablation is other backbone of the treatment. So usually treatment consists of induction therapy, then autologous transplant, followed by consolidation therapy, and usually maintenance with lenalidomide or another agent. In all the patients that are not transplant eligible, we used to observe very poor results because the patients couldn't get the autologous transplant. but more recently, so they received lenalidomide only, but more recently, daratumumab has been introduced, which is a targeted agent for CD38, which is on the myeloma cells. And this has been added to treatment both in the younger patients and in the non-transplant eligible patient. So that's the first of the targeted agents that was identified and used in multiple myeloma. And now, more recently, like in some other diseases, immune therapies have been introduced. So you could say there's two classes at this moment for multiple myeloma. One is the bispecific antibodies that target an epitope on multiple myeloma, mostly BCMA, which is the B-cell maturation antigen. And because they are bispecific, they also target T cells. So they bring the T cells to the myeloma cells, so to say. And there are several of these bispecific antibodies available now, and some can be used even already in the clinic, especially teclistamab. But there are others like elranatamab and more. And more recently, even another target on the myeloma cells was identified. This is GPRC5. And this is, of course, very welcome, because now we have not one, but several targets on the myeloma cell. And talquetamab is an agent that was developed and is now being tested in clinical trials for this purpose. Of course, there are many other immune therapies that are being developed and already in, let's say, phase 1, phase 2 type of trials, including trispecific antibodies and more. And then the last addition to our therapeutic arsenal is the cellular therapy, and specifically the CAR T cell. CAR T cells mostly are directed against BCMA again, but also other targets are investigated. And these CAR T cells, they have the advantage of having strong binding to the target, but they have to be used only once. It's not like continuous therapy with the bispecific antibodies. Although they target the same protein on the myeloma cells, BCMA, the use of these is different. So either continuous treatments with the bispecifics or single treatments with CAR T cells like cilta-cel or ide-cel, and there are more. And so depending on the situation, depending on the patient class, one of these options can be chosen by the doctor. Now there are many more developments in myeloma, like in lymphoma and leukemias, to develop targeted antibodies, either ADCs, which is an antibody that carries a drug load, or bispecifics or trispecifics directed against different antigens on the myeloma cell.
Can you compare, or how do you choose between using bispecific antibodies against BCMA or GPRC5D or CAR T cells? Because it's the same target, but how do you choose between these two types of therapy?
Well, let me start that by saying in Europe, the availability and the access to these novel treatments is limited. This is because of approvals are later than in the US mostly. And also the production facility for CAR T cells, especially cilta-cel, the building has been delayed, so there's not enough available right now, but this will improve very soon. So for the most part, I think the choice is determined by do we want to give a single treatment in a patient and then look to the effect, or do we want to give a continuous treatment, mostly then combining with other agents. So it's up to the treating physician to make the choice together with the patient. But access to bispecifics is also limited because of the cost. So there's a cost issue with these new agents. There is an access issue because of availability. And also, people need to learn about these novel agents. So it's early in the development, especially in the clinical development. In the next 2 or 3 years, I expect that these agents will be introduced widely in the treatment of multiple myeloma. And not only at end-stage disease, when we usually apply the novel agents, but primarily now in earlier stage, like second line and even front line. So the European Myeloma Network, for example, is performing a trial right now comparing CAR T cells with autologous transplant in newly diagnosed patients. So first treatment CAR T cells in order to see if this is superior to standard autologous transplant.
So with all these new targeted therapies becoming available, how much has the prognosis of improved for a multiple myeloma patient? Can you think that can you cure multiple myeloma, or will that be possible soon?
Yeah, that's a $1 million question, of course, literally, because if we know for sure that we can cure myeloma with these novel agents, then I think we would be willing to pay a higher cost. Right now we don't know that. Myeloma is a disease that's always considered to be incurable, but long remissions are observed. For example, we presented the data of the PERSEUS trial at ASH, which uses daratumumab plus standard therapy, comparative therapy, conventional therapy alone. And the results are very impressive. The improvement of progression-free survival is huge, as is the CR rate, complete remission rate, and also the MRD negativity rate. We expect that with this treatment, the progression-free survival will be 10 years. So what's cure? What is cure? Most of these patients are older patients. If you can achieve 10 more years in life without disease, apparent disease, it's almost like cure. And we think that with these novel agents, we should try to achieve this, that more patients, the majority of the patients, will have a long-lasting remission, are free of disease symptoms, and also can resume their normal life as much as possible. That would be a very good achievement in my view.
So you have worked all your life in this field. What do you find most fascinating, promising at the moment? What makes you excited about the future for these patients?
So indeed, I have a history in multiple myeloma. I worked on it for a long time. And always my personal goal has been to learn more about the effect of drugs and treatments. Why are they effective in some patients and why are they not in other patients? So in Rotterdam, we do a lot of translational studies, many international collaborations to identify molecular factors in the patients who are included in all these trials, to see what determines the outcome, if there are biological markers for prognosis, if we find targets for potential novel drugs. And we can only find out if we have large numbers of patients in the trials who, from whom we can use the cells, the cancer cells, to do these investigational studies. And if I look back over the years, there has been a tremendous progress in that field. We know a lot more about this disease than we did 20 years ago.
What would be your key takeaway message for a general hematologist treating patients that come to them and are likely to have multiple myeloma?
So I would say the progress that we have made with the treatment of multiple myeloma, diagnostics and treatment, is largely due to clinical trials. So I would encourage doctors to participate in clinical trials, and for two reasons. One, usually the outcome in clinical trials is better than outside clinical trials, because you have to follow a protocol. Adherence to the protocol is important, and this improves the quality of the treatment and of the outcome. Secondly, I would say try to apply the novel treatments in your patients at an earlier stage of the disease. Don't wait for the, let's say, fifth line or so, and these agents may still have an effect, but it's limited and of short duration. In first line or second line, if possible, the effects are much better, and that will be a benefit for the patient and also for, I think, for the general practice.
Is there anything else that you would like to add for our audience?
Now, this is an exciting era. There's never been more progress in the field of myeloma than now. This is also true for non-Hodgkin lymphoma, for other diseases, but not so much, for example, for acute myeloid leukemia. So myeloma is one of the front runners of therapy development in hematology. And this is good for myeloma, but I think it's also good for the whole field to observe that we can make progress, which is there to stay.
Thank you for this very enlightening discussion. Thank you, Professor Sonneveld, for sharing your expertise with us, and to all of you for listening.